Thank you, Sposi, and thank you all AIS for this opportunity. I'm going to discuss the non-surgical methods of managing paralytic strabismus. No financial interest. Basically, once you start doing strabismus, you don't have financial interest actually. So, uh, so why go non-surgical? Because their initial mode of treatment has to be non-surgical. You can't directly jump for surgery. In cases where surgery is contraindicated for any medical reasons, or many of the cases of paralytic strabismus, they show recovery or they show variability with time. So you cannot actually judge what is the angle which you need to treat them. Also, many of the cases, even if they are corrected, may be non-fusers and can lead to diplopia. So we have to take care of that also. And also, if the patient is not convinced with the realistic goals of surgical treatment, then better to wait till he gets convinced and try to manage him non-surgically. Strabismus can be comitant and concomitant. I'm going to discuss only the modalities of non-surgical treatment of paralytic strabismus, which happen to be all of these. One by one, I'll just explain in short. Glasses do not correct the paralytic strabismus, but they act as not only for refractive correction, but they can provide a base on which you can do either occlusion treatment or prism therapy. Also, cases of myopathies or third nerve palsy, if crutch glasses you are contemplating, then they can be added on to the glasses which the patient is already wearing. Occlusion, they do not provide any binocular vision, but they just block the binocular diplopia. So in cases of third nerve paralysis with ptosis, obviously patient will not have diplopia as in first patient, but sometimes over glasses you can do apply an occluder to avoid binocular diplopia. It is mainly to avoid binocular diplopia, nothing beyond that. Orthoptic exercises also have a limited success. It is believed that, I mean, what we advise is to occlude the normal eye and try to tell the patient to try to move the eye in the side of the paralytic muscle. How much that helps, we really don't know about it, but a patient feels that he's doing something about it. But the definitive treatment to correct the binocularity is either prisms or chemodenervation. Prisms should be have a huge role in paralytic strabismus because they provide stable they provide diplopia free interval, especially in primary gaze and the down gaze. The advantage is they provide binocular vision and early relief from binocular diplopia, but the disadvantage is in case of cyclotropia, or if the angles are variable, then prisms may not be the treatment of choice. The basic concept is the image is displaced by the prism towards the base. So if you are applying a prism for correction of binocular diplopia, it should be apex towards deviation or base towards the face turn. There are two ways of doing using prisms. Either the cheaper way is to incorporate them into the glasses, or the expensive way is the Fresnel prisms. Prism glasses have an advantage that they are cheaper and they can correct up to around 10 to 14 prism diopters if you divide them into two eyes. The disadvantage is the glasses are thicker, and also they cannot be used for large angle squints. So for large angle squint, Fresnel prism is the treatment of choice, where the multiple prism segments have an additive effect, and they correct large angle deviations or large angle squints. The disadvantage of Fresnel prisms is that they are expensive and availability is always an issue. Also, that over time the dust gets settled into the crevices of the Fresnel prism and provides a loss. The visual quality goes down. Initially, you have to try it with the Fresnel prism set to correct the diplopia in primary and down gaze, and then you have to incorporate it as a sticker from the inside of the glasses. Even if the patient has a fourth nerve palsy and diplopia and down gaze, you can apply the Fresnel prism only on the lower part. So as I mentioned that the prism have to be applied with base towards the face turn. Like in case of esotropia, it should be base out. So the last point in this is the chemodenervation, where we temporarily paralyze the ipsilateral antagonist and thereby correct the diplopia, or at least reduce the diplopia. The drug of choice is botulinum toxin A, more commonly available as Botox, but there are other options also. What it does is that it inhibits the release of acetylcholine at the neuromuscular junction, thereby leading to flaccid paralysis of the concerned muscle. It can be used for large angle deviations, even for medical causes, if the patient wants an early relief from diplopia. It is available in one of out of these brands, out of which Botox A is the most commonly available. Uh, the advantage of chemodenervation is that it not only corrects diplopia but avoids contracture of ipsilateral antagonist. So if surgery is contemplated later on, the results might be much more predictable. The disadvantage is the effect is temporary and also availability. But I think availability to me is not an issue if you really liaison it with one of the neuro surgeons who use it or neurologists who use it more commonly. The technique is 2.5 to 5 units is injected into the belly of the muscle. It doesn't have any cumulative effect. Like if it's a large angle squint, you don't need to inject more. It's more unit. That is not what it is based upon. Just sharing one patient who had a binocular diplopia in a case of 6 nerve palsy, right sided 6 nerve palsy, as suggested by PBCT. There are two ways of doing it. Either you inject it directly into the belly under visualization, so the chances of spillover are not there. I mean, you don't need to dissect this much because this was along with a medial rectus recession. That's why I dissected very large. Or you can directly do it in OPD also, where you can hold the muscle with a superior rectus forceps like in cataract and inject it into the belly of the muscle. So here we don't open the conjunctiva that much. Usually the effect is seen in 1 week or 2 weeks itself. The diplopia free or reduction in diplopia is definitely there. I haven't seen, but as mentioned in literature, the most common complication is spillover. So to conclude, non-surgical treatment is the first line of managing paralytic strabismus, and paralytic strabismus due to medical causes, they recover completely, but if the patient wants early recovery, botulinum can be used in those cases also, and it provides early relief in binocular diplopia. With this, I want to thank you.
Thank you, Dr. Rishikesh. Just one question. Have you ever used the Fresnel prisms?
Yes, ma'am. I have used it in a couple of cases in an elderly patient, and as I mentioned, this is my own experience that the quality of the vision goes down. I mean, because there are a lot of crevices in them. So if they are more than 1 year or
But can we reuse them?
after cleaning, I have not tried it, but
No, man,
we
you can
can.
just remove it from that patient and can
Yes,
we
yes,
reuse
but
them? Because
it's better that we do it rather than allowing it.
yeah, because Dr. Suma was yesterday saying that in cases of intermittent XT, she does it does a prism adaptation test in the
Yes.
OPD. So they must be able to reuse it. Okay.
The advantage of this the prism set, Fresnel prism is for that has a lot of advantage actually to check for predominant.
Okay. Okay.
We remove them, clean them, and you can stick it.
Okay.
Yeah, yeah. It is only for prism adaptation test, not for use, not for use.